Giant cell arteritis, otherwise known as temporal arteritis, is a large vessel vasculitis that occurs in individuals over the age of 50 and usually older individuals in their 70s to 80s. The most common symptom is a severe, non-remitting temporal headache that does not respond to the usual analgesics. There can be superficial scalp and facial tenderness, and individuals may complain of pain while brushing their hair or shaving their face. Another symptom is jaw claudication, which is typically described as a dull aching or cramping of the jaw muscles while chewing or talking. Patients can also present with polymyalgia rheumatica, usually with prominent symmetrical pain and stiffness across the shoulders and hip girdles that is worse in the mornings. GCA also affects the aorta and its major proximal branches, which can lead to arm claudication. Inflammation of the large vessels here can lead to stenoses, aneurysms, and aortic dissection. Complications of GCA include vision loss, which can be transient or permanent, and stroke involving the vertebrovascular territory. True intracranial GCA with CNS vasculitis is rare. When diagnosing GCA, certain criteria should be met. Individuals must be over the age of 50 and again typically in their 70s. ESR is usually over 50 and CRP should also be elevated as well. All suspected patients should be referred to rheumatology and for an urgent temporal artery biopsy, which still remains the gold standard for diagnosis. Temporal artery ultrasound is available in some centers, and here we're looking for the characteristic halo sign. However, sensitivity with ultrasound is not very high and varies depending on technical factors, so a negative ultrasound does not rule out the disease. First-line treatment for GCA is with high-dose prednisone. 1 milligram per kilogram dosing up to around 60 milligrams should be started as soon as possible. If there is vision loss, we normally give pulse methylprednisolone for 3 days as well. Initiation of prednisone should not be delayed by timing of the temporal artery biopsy. Around 50% of patients can be treated successfully with prednisone alone, which means that around 50% may relapse and need a steroid-sparing agent. Methotrexate and interleukin-6 inhibitors are the most common ones used, and a rheumatologist can help decide which is more appropriate for each patient. Hi, my name is Joanne Jiang, and I am a vasculitis fellow at Mount Sinai Hospital. Thank you for watching this video, and if you'd like more information about vasculitis or giant cell arteritis, I'd recommend visiting vasculitisfoundation.org for more information sheets. I am also working with the Vasculitis Foundation of Canada to produce information sheets for our Canadian citizens as well.